My name is Ghaith Noaiseh. I'm a rheumatologist at the University of Kansas Health System. I run the Sjögren Center at the University of Kansas, and my passion about the disease dates back to when I was in training at the University of Pennsylvania under Fred Vivino, who's a known name in the field, recently retired. And I developed a passion for the disease that, culminated by joining the faculty at the University of Pittsburgh for 7 years, where I established Sjögren Clinic there. Then I moved 2019 to the University of Kansas. For the same reason, basically, established Sjögren's Clinic, and I have a large portfolio of clinical trials, and I collaborate with other academic centers on several projects. I'm also one of the board members of the Sjögren's Foundation, and quite involved with developing guidelines for the management of different aspects of the disease. First of all, I'd like to start by saying it's actually, we prefer the term now Sjögren's disease, not Sjögren syndrome, because when you use the term syndrome, we're vague. We're just saying constellation of symptoms, the underlying cause of which is unclear. Whereas we believe now Sjögren's is a very well-characterized autoimmune rheumatic disease that deserves to be called Sjögren's disease. And this has been actually the theme of a recent publication that came out a couple of years ago, or maybe a little bit less than that, by experts in Europe and the United States to try to emphasize that point. So at any rate, Sjögren's disease is an autoimmune rheumatic disease that has a tendency of affecting middle-aged women, but it can affect men and women of all ages, basically. And it has a plethora of different manifestations that could range from mild to life-threatening. But the cardinal features of the disease are characterized by the presence of dry eyes, dry mouth, but also fatigue, joint pain, amongst other potentially serious and life-threatening manifestations, such as lung inflammation, we call ILD, and even lymphoma, which is fairly common in those patients. I have to say that there's a huge unmet need with regard to the management of Sjögren's, and the disease continues to face certainly major treatment gaps. First of all, there are no approved systemic disease-modifying therapies, and unlike diseases like rheumatoid arthritis and lupus, in which case we have biologic therapies that are available, that have been available for a while, management of Sjögren's really relies on off-label use of different drugs and symptomatic approaches. And current treatment guidelines focus on really management of symptoms via different modalities, artificial tears, let's say, and topical cyclosporin for eye dryness, saliva substitutes, and secretagogues, which are saliva stimulants that we use orally to improve oral dryness, and also general measures such as exercise to improve fatigue, or hydroxychloroquine and antimalarial that can help with certain symptoms, basically, usually fatigue and pain. For those who have more severe systemic disease activity, clinicians often borrow treatments from other autoimmune rheumatological disorders, including steroids, methotrexate, or even rituximab, despite the lack of strong evidence to support the use of these medications. Furthermore, patients often struggle with persistent dryness, fatigue, and pain, and these are, in fact, the symptoms that significantly impact the quality of life and are poorly controlled via current therapies that we have now. And I would say fatigue in particular remains a very difficult and challenging symptom to manage, often unresponsive to immunosuppression. Additionally, systemic manifestations like arthritis, lung inflammation, or lung disease, vasculitis, and neuropathies also add complexity, and high disease activity has been linked to increased mortality and lymphoma risk, as I highlighted earlier. Yet we lack safe and effective ways to reduce systemic inflammation. I mean, that's reality. And I want to finish by saying that the cumulative effect is substantial disability for many of those people, mental health strain, and also high healthcare use and cost. And many of those patients, in fact, cycle through specialists without a unifying treatment strategy, leading to really a lot of frustration and sense of invisibility. So this is a novel therapy being explored in Sjögren's disease, but also other autoimmune disorders. And what it does is that this drug really blocks the what we call the neonatal Fc receptor, or the FcRn. This is a key protein that normally protects immunoglobulins in the blood, called IgG, from degradation. And by inhibiting this receptor, this drug, Nipocalimab, accelerates the clearance of these antibodies, IgG, from the bloodstream. These antibodies also include autoantibodies that contribute to the inflammation of Sjögren's, particularly anti-SSA, or we call anti-Rho antibody, and also anti-SSB or anti-La antibodies. These antibodies are believed to form immune complexes that can drive tissue damage and inflammation, perpetuate inflammation, sort of, in the glands, but also in other organs. And reducing the level of these antibodies basically may help and interrupt the cycle of inflammation and lower systemic disease. And unlike therapies that target the B cells to reduce antibody production over time, Nipocalimab acts directly on the circulating antibodies, offering potentially faster and broader immunomodulatory effect. In the Dahlia trial, those patients who had active disease who received Nipocalimab showed meaningful improvement in the systemic disease activity after 24 weeks of treatment, even when prior treatments like hydroxychloroquine and low-dose prednisone had limited effect. The improvement in the primary endpoint using a tool called ClinSDI, improvement of the ClinSDI score, while was modest numerically, it was clinically significant, especially given that many previous biologic trials have failed to outperform placebo. So this is a common problem, obviously, in Sjögren's research. Importantly, this benefit came without notable increase in infection or major lab abnormalities, aside from expected reduction of the serum IgG and albumin. This suggests that this drug, Nipocalimab, can in fact reduce autoimmunity while largely preserving the broader immune function, although, again, monitoring remains essential for those people. Another advantage is it's relatively fast in the way it acts, so it has fairly rapid onset. In other autoimmune conditions, this blockade of this receptor that we call FcRn have shown clinical effect within weeks. And in Sjögren's, those patients who received the drug showed improvement as early as week 12 in certain symptoms, including fatigue. Because the inhibition of the FcRn receptor is reversible, IgG levels do recover rather quickly after stopping therapy. And this is important because it allows clinicians, let's say the drug finds its way to getting approved and we have a successful phase 3, this could allow clinicians to adjust dosing if needed. And this is an important safety feature compared to longer acting biological therapies, for example. I also want to highlight that Nipocalimab may be also especially relevant for the majority of Sjögren's patients who are seropositive for this antibody, the anti-Rho antibody, and also the anti-La. We actually did demonstrate in the study that those who have high titers of these antibodies and systemic features may benefit the most. This is also very important, I think. And early signs of symptom improving, including improvement of dryness, fatigue, and also pain, were observed by week 24 in some of those patients. And also we observed improvement of the saliva flow, which suggests potentially reducing inflammation, might help restore some of the gland function. This is also essential and important. And while these symptomatic effects need confirmation in larger phase 3 trials, I think the mechanism offers reason for optimism. This was a phase 2 study that we refer to as Dahlia trial, and it evaluated the drug Nipocalimab in adults with moderately severe primary Sjögren's disease. And those are specifically seropositive patients, those who are positive for anti-SSA/Rho antibodies, and also had active disease defined by ClinSDI score of 6 or more. Overall, 163 patients were randomized to receive either low dose of the drug, 5 milligram per kilogram versus 15 milligram per kilogram, that's the high dose, versus placebo, every 2 weeks up to week 22. The primary goal of the study was to assess the changes in ClinSDI at week 24. And in short, the ClinSDI is a measure of systemic disease activity, excluding lab-based domains, and that was intentional with the goal of avoiding confounding here. The high dose, in brief, met the primary endpoint and showing significant reduction of disease activity compared to placebo at week 24. And patients in this group improved by an average of 6.4 points versus 3.7 in the placebo arm. This is a meaningful delta, I would argue. And the mean difference was minus 2.65, basically, that reached statistical significance. The lower dose, unfortunately, did not show a meaningful difference. And we also looked into secondary outcomes, such as certain parameters, including SDI score and composite responses, also were measured. And while patient-reported symptoms, including fatigue, dryness, and pain, did not reach statistical significance, there was a trend that we observed towards improvement were seen by week 12 of starting therapy. And this continued actually throughout up to week 24. Notably, the saliva flow was approximately twice as high in the high-dose Nipocalimab treatment compared to those receiving the placebo, which suggests, again, potential benefit in the glandular function through tear production, although tear production did not differ between the placebo and the high dose. As expected, this drug led to rapid and substantial reduction of the serum IgG, with the high dose achieving approximately 70 to 75% drop from baseline. This includes lowering the pathogenic autoantibodies, anti-SSA specifically. And importantly, patients who had the highest baseline autoantibody levels, as I highlighted earlier, had even larger delta compared to other patients. Safety in general was favorable, and we did not observe any deaths. We did not observe any serious infections. And overall adverse event rates were similar across groups. I would say that there were some mild lab changes, such as transient drops in the albumin or rising cholesterol, but these were really not clinically significant. IgG levels, importantly, IgG levels recovered and went back to what it was within a few weeks of discontinuing the study drug, basically. In summary, I would say Nipocalimab at the high dose, 50 milligram per kilogram, showed meaningful clinical benefit and a good safety profile in Sjögren's, which supports the strategy of targeting IgG autoantibodies with the goal of reducing disease activity. I think the Dahlia study does offer, in my opinion, a turning point in Sjögren's disease. It does provide a clear proof that targeted therapy can meaningfully reduce disease activity. This is very important. For patients, this is more than just data. It's real hope, I would argue. And after years and years of limited options like using eye drops and steroids, now we have evidence that a new kind of drugs can intervene and improve the disease inflammation or disease process overall. Many have watched the progress in the field of lupus and rheumatoid arthritis and wondered when Sjögren's would catch up, basically. And Nipocalimab's success, along with the other recent agents that have been associated with positive results, signals that the field is finally moving forward. It sort of validates that Sjögren's disease as one that deserves more and can respond basically to active treatment, not just symptom management, basically. And for clinicians, this marks a shift in expectations, no doubt about that. We may soon have disease-modifying options that never existed before. The trial results encourage us to move beyond supportive care and start aiming for measurable improvement in disease activity. This is reminiscent of the shift in lupus care after the belimumab approval almost 15 years ago. While belimumab, a known drug in the field of lupus, had modest efficacy, it still changed the conversation. And this is also an essential observation here. In Sjögren's, Nipocalimab could allow us to intervene in the underlying immune process, not just the consequences. And again, I believe this is essential. And if the FcRn receptor blockade strategy can reduce systemic inflammation, it may also reduce long-term complications like organ damage or severe flares. I would also argue that the trial also elevates Sjögren's in a way in the therapeutic landscape. Why do I say this? Well, this is a publication in the Lancet, high-profile journal, as you know. Therefore, Dahlia joins the other high-profile studies that are reshaping how the disease is really viewed. This visibility encourages clinicians to screen patients for the diagnosis of Sjögren's more and more actively, I would argue, and also inform academic centers to invest in Sjögren's research. This is a phase 2 study, we have to remember. So this is still, fresh data. It's still and promising. It's still not the final step. We still here need more data. So basically, the next step would be clearly the phase 3 trials that are going to be performed testing Nipocalimab in Sjögren's patients, both to confirm its safety, but also efficacy in a broader population of patients with moderately severe autoantibody positive Sjögren's. These studies will likely focus on the higher dose, since we already have a signal from the phase 2 study. And the phase 3 program typically runs longer, typically between 48 to 52 weeks, to assess, first of all, sustained disease control, to long-term safety, but also the impact on symptoms and organ damage. The regulatory approval will likely depend not only on statistical significance in the primary endpoint, but also clinically meaningful improvement in both patients and physician-assessed disease activity. So an example for that is that you would need really to prove that the tool that you're using to measure disease activity also mirrors improvement in significant symptoms such as fatigue and dryness that patients experience. I would say that future trials may refine endpoints based on DALIA insights. In this regard, I think ClinisDy proved useful and may be paired with other tools to capture multidimensional improvement in those patients. I would also argue that safety monitoring would be critical here, and we need longer follow-up to help detect any rare adverse events as we monitor the IgG level in those patients and assess also immunogenicity. The phase 3 trials will also address very important unresolved questions. Will longer treatment lead to clearer improvement in dryness and fatigue? This study, DALIA, showed a trend, but not definitive changes in certain domains of patient symptoms. And if the symptoms remain an improved, combination therapy may be needed. For example, pairing Nipocalimab with agents that would stimulate gland function, let's say, in order to achieve improvements across many domains. Another question is whether seronegative patients might benefit. And I just want to remind you that we only recruited patients who were seropositive, defined by positive anti-SSA or anti-Rho antibody. And therefore, future study could include small cohort and explore that further. So there are many things that we need to follow upon basically here to ensure that this promising initial step would carry forward and give us promising results in future studies. I just want to finish by saying there's unmistakable and unusual, I would argue, excitement in the field of Sjögren's and the Sjögren's community. Like, just to give you a feel of this, I finished my training in 2012 and there was nothing going on in the field at all. It was so stagnant that one of the actually leading experts in other domain disease, who was my mentor at Penn, advised me almost 8 years later. And I remember meeting with him around 2020 or 19, something like that. And he said, Ghaith, what are you doing? I said, I'm interested in Sjögren, I'm focusing on this. Like, there's nothing going on. And that was 2019 or 2020, I can't remember. Just go do this or that, et cetera, et cetera. And here we are now. Sjögren's is getting them, I would argue, the most excitement amongst all other autoimmune rheumatic diseases. And this was very palpable during the most recent international meeting, American College of Rheumatology meeting in Chicago only 2 weeks ago. And I think the future is going to be very bright. This is only one of the important steps that are going to be coming out in the next 2 years. I would argue 26 and 27 would be the culmination of all this effort of different trials, of all this hype that I hope is going to translate positively into good outcome for everybody. So.